All right, so let's do a quick high yield lung cancer review for the PANCE. Thank you so much, everybody, for all of the really nice comments. I really do appreciate that. So thank you so much for that. And if you haven't subscribed to the page yet, please do. I'm coming out with new stuff every week, and it really helps get the word out about the page on YouTube. The more people that have subscribed. So thank you for everything, guys. And let's go ahead and get started with lung cancer. So first thing that I want to go over with lung cancer is related to pulmonary nodules. So pulmonary nodule is likely going to be that incidental finding you saw on a chest x-ray that led to the diagnosis of lung cancer. So first of all, what is a pulmonary nodule? So it's defined as a small, well-defined lesion that's surrounded on all sides by pulmonary parenchyma. Most nodules are going to be benign, about 75%. So most of the time, they're not going to be cancer. Now, pulmonary nodules are also defined specifically by their size. So they have to be less than or equal to 30 millimeters. And size is important because if it's over this size, it's actually considered a pulmonary mass rather than a nodule. So 30 millimeters or less is going to be a nodule. Any larger than this is going to be considered a pulmonary mass. So it has to fit that criteria as well. Now, let's go over what's important about nodules is the malignancy risk. There's low risk features and there's high risk features. When you're risk stratifying in real life, you're actually going to use a calculator. There's Mayo Clinic has one. There's the Fleischner criteria and things like that. So don't go crazy with this, but you just need to know some basics to kind of guide you on a vignette to know, whether there's a high or low risk chance of malignancy. So let's get started with our low risk features, all about our S's. So size, surface, smoking status, and seniority, aka the age of the patient. So first thing, the size. Now I put a specific size because it makes it easier, but there's really no need to memorize a number here and waste valuable space in your head. There's not a specific number to know anyways. It's not like less than 5 millimeters is always benign. This is not the case, but generally less than 1 centimeter, the risk is minimal, about 2 to 6% chance of malignancy compared to larger nodules over 2 centimeters where there's around a 50% chance. So all you really need to know is the larger the nodule, the more common it's going to be malignant. So small generally is better. Smooth borders, that's another important one. It's also maybe described as a popcorn calcification. So if you see a popcorn pattern or popcorn calcification, that's this dense, diffuse calcification. This is a classic finding in benign tumor, specifically one known as a hamartoma, which is a benign finding. And then also remember your smooth, well-defined border. So this is what a hamartoma looks like. This is going to be a popcorn calcification. You can see it's nice and smooth around the edges, has this dense calcification in the center. This is a benign nodule, nice and smooth, dense calcification there. That's a popcorn calcification. So those are your benign findings. Next, non-smoker. That one's pretty common sense. I'm not going to really go in any deeper than that. And then young. Again, there's not a specific age here, like a nodule size. There's not a specific number. But no, the older you are, the greater chance of malignancy. So patients in their 30s have around a 3% chance of malignancy compared to patients over 60 where it jumps to 50% or higher. So low risk features again, small, smooth, young, and non-smoker. That's going to be your low risk features. Now let's do the opposite end of the spectrum. That's going to be your high risk features. I'm adding an S here. So size, surface, smoking, seniority, same as in the low risk, but segment. So this is going to be the segment of the lung involved, which I'll go into in a second. So large, over 2 centimeters. Again, remember your risk jumps up to about 50% or higher when they're this large. Now, instead of that smooth border with high risk features, you have a spiculated border. So the border of malignant nodules, they're often uneven. They almost look spiky, and it's known as a spiculated pattern, and that's highly suspicious for malignancy. So let's take a look at what that looks like. So this is a spiculated nodule. You can see almost spikes coming off of here. This is very suspicious for a malignant nodule. Obviously this one was a malignant nodule. So this is what a malignant nodule is generally going to look like. Spiculated, it's not going to have that nice smooth border. You have all these spikes coming out. So you compare that to your benign one we saw before, nice and smooth, nothing poking out here. So that's your spiculated nodule, very suspicious for malignancy. Smoker, another common sense one. Old, again, there's no number here to say, but the older the patient, the higher the risk. So if you see a vignette and the patient's like 75, there's a much higher chance of malignancy if a patient has a nodule. So for your high risk features, there's one more I want to go over, and that's your segment. So upper lobe segment of a lung. About 2/3 of all malignant nodules are going to be found in the upper lobes. So that's what you need to know for your high risk features. So high risk features, again, large, spiky, old, smoker in the upper lobes. That's what you need to know for your nodules, and that's it. Don't waste your time with anything else. Now, imaging workup, this is the only other thing you need to know, but this is pretty basic. You're going to do a chest x-ray. That's probably going to be where you found it incidentally. But to actually diagnose and kind of get a better idea of the likelihood of malignancy, determine the edge characteristics, the pattern of the calcification, better idea of the specific size and location, CT of the chest is going to be your imaging test of choice for your lung nodules. All right, so let's move into the clinical manifestations of lung cancer. There's really 4 things that you're commonly going to see in real life and on the vignette. That's going to be a cough, chest pain, hemoptysis, which is coughing up of blood, and weight loss. So this is the presentation you're most commonly going to see in a vignette. But then you have to take this a little bit further and decide, is this lung cancer or is it maybe from an infective organism like tuberculosis? So you have to look at the keys, which is going to guide you from one to the other. So if it's TB, they're likely going to mention somewhere in the vignette some immunocompromised risk factor. The patient's going to have HIV, maybe they're homeless, they're from a TB endemic country. That's going to be in the vignette for TB. Now, if it's lung cancer, they're probably going to mention maybe like a 30-year history of smoking. They're going to mention maybe a paraneoplastic syndrome, so they may say the patient has dilated neck and chest veins caused by superior vena cava syndrome that we see in small cell lung cancer. There's going to be something to differentiate so you can decide which is which. But this is generally what you're going to see in a vignette and in real life in a patient with lung cancer. So those are your clinical manifestations, those 4 things. Now, there's a couple different types of lung cancer. There's your non-small cell and there's your small cell. So they're 2 different types. They have different prognosis. They have different histologic findings, different treatment options, which we'll break down. And then non-small cell is broken down into different subtypes, which we'll also review. Let's start with small cell. Small cell lung cancer, there's a few things that I want you to know about this, and I'm not going to go crazy with a million things. There's really only like 4 or 5 things that I feel like you should know. First thing is it's extremely aggressive, very aggressive. It spreads fast. Most of the time when small cell lung cancer is diagnosed, it's already metastasized. It's not common that it hasn't. That's the common finding in small cell lung cancer, that it's already metastasized at the time of diagnosis, so very aggressive. The other thing is that it's very responsive to chemo, plus or minus radiation, but it's all about chemo in small cell lung cancer. So surgery is rarely ever used. It's just not effective, but small cell is very responsive to chemo. That's your number 1 treatment option. The unfortunate part is even though it responds well to chemo, as well as works well with radiation as well, the cancer is usually going to relapse in 2 years despite the treatment with chemo. So that's the unfortunate part about this cancer. The other thing you need to know is that it's commonly associated with what are known as paraneoplastic syndrome, so like SIADH, Lambert-Eaton syndrome. You're going to see it most commonly in small cell. I'll go over those towards the end too. And then the other thing you need to know is that this is very common in smokers. So you may be thinking, well, yeah, all lung cancers are associated with smoking, but there's some that we're going to go over, like adenocarcinoma, that can actually be seen in non-smokers. But in small cell, it's almost always a smoker. About 98% of patients with small cell are going to have a smoking history. So the only other one that's has as significant an association with smoking is squamous cell. But just remember, if the lung cancer starts with an S, it's caused by smoking close to 100% of the time. So that's really important for small cell as well. And then finally, the last thing that you should know is that the mass in small cell lung cancer is most commonly located in the central part of the airway, so central location of the mass. So how do you remember the things that you need to know about small cell? This is how you remember. So small cell lung cancer, SCLC. S stands for smoking. Remember, cigarette smoking, strong association here. Central, mass often located in the central part of the airway. L stands for Lambert-Eaton syndrome. That helps you remember the paraneoplastic syndromes that are common in this type of cancer. And then finally C, because chemo is your number 1 treatment option here. It's extremely responsive to chemo. So that's small cell. Not too bad, just a few things that you need to know. Now let's move on to our non-small cell cancer. So non-small cell cancer, you need to know that this is going to be your most common type. So it accounts for approximately 85% of all lung cancers. And then also with this one, compared to small cell, which really only worked well with chemo, maybe radiation, this you have multiple treatment options available. So surgical resection, chemo, radiation, and then surgical resection is actually your best treatment option. It's your best opportunity for long-term survival in these patients, or a potential cure in patients that have resectable non-small cell lung cancer. And then finally, you have subsets with non-small cell. Small cell is just that one. Non-small cell actually has a few different subsets. So those are adenocarcinoma, squamous cell, and then finally large cell. So let's go into each different subtype and go over what you need to know for the exam. So adenocarcinoma, one thing you need to know about this is by far your most common type of lung cancer. This is about 1/2 of all lung cancer cases are going to be adenocarcinoma. The other thing is that it's your most common type in patients that are non-smokers and patients that are women. So this is very unique about this. And again, it's your most common type of lung cancer, so it's going to be your most common of everything. But in this case, it's actually more common in women. Proportionally, more women than men are going to be diagnosed with adenocarcinoma versus other types like squamous cell and things like that. And then it's also the most common type in non-smokers. So that's your unique thing that you need to know about this, and this will probably be what's going to be on the vignette, because you need to know that adenocarcinoma is going to be the most common type to be seen in non-smokers and women. That's key. You need to know that. Couple more things that you need to know. This mass, instead of being centrally located in small cell, is going to be peripherally located. So adenocarcinoma as well as large cell carcinomas are the only ones that tend to be located peripherally in the lungs. The masses are generally peripherally located in the lungs. And then finally, on histology, on microscopic findings, you're going to see maybe mucin or gland formation mentioned. So this type of cancer arises from the bronchial mucosal gland. So if they mention biopsy findings with mucin production or gland formation, you should be thinking adenocarcinoma. This is not so high yield, but just be aware of that. So that's adenocarcinoma. Just a few things to know. Again, remember, most common type. If you see a non-smoker or a woman, right away be thinking adenocarcinoma. Remember, it's peripherally located. Only this and large cell are. And then finally, any histologic findings that indicate mucin or gland formation, adenocarcinoma should be what you're thinking about. Next, let's move on to squamous cell, another type of non-small cell lung cancer. Squamous cell, again, like I said, with small cell, these two are very commonly associated with smokers. Really high chance, about 98%, if you have squamous cell or small cell, that they're a smoker. So remember, again, if it starts with an S, the cancer, you should be thinking smoking. That's really important here. Other thing about squamous cell, cavitary lesions. So squamous cell carcinoma can often have extensive necrosis, which results in this cavitation. And the classic manifestation you'll see with squamous cell is a cavitary lesion in a proximal or the central bronchus. Hypercalcemia. So this is the most common type of lung cancer that's associated with hypercalcemia. It's from the abnormal secretion of something called parathyroid hormone related protein, so PTHrP, from the tumor. And this PTHrP that's released causes the body to release calcium, retain calcium from the kidneys, increase calcium reabsorption from the bone. It mimics what PTH does, but long story short, just remember, in squamous cell, hypercalcemia can commonly be seen. Mass is often going to be centrally located. And then finally, on histologic findings, you're going to see keratinization or keratin pearls may be mentioned. So that's just an abnormal squamous cell that form these concentric layers. So you may see any of these mentioned if it's a squamous cell lung cancer. So how do you remember the things you need to know in squamous cell? You remember that squamous cell lung cancer is not spelled with a Q, but spelled with a C, because it's all about the C for squamous cell lung cancer. So what does the C stand for? Centrally located. Cigarettes, remember, squamous and small cell, strongest association with cigarette smoking. C, calcium elevation, hypercalcemia that I mentioned. And then finally, C stands for cavitary lesions. So those are the main things that you need to know with squamous cell lung cancer. Also remember, in adenocarcinoma and squamous cell, you may see something known as PANCE tumors. So this is the superior sulcus tumor. I'll go over a little bit later when we go over the paraneoplastic syndromes. It's a tumor located in the superior sulcus. It's associated with both adenocarcinoma and squamous cell. Squamous cell used to be the most common cause, but now adenocarcinoma is more commonly the more common cause of the PANCE tumors. All right, so let's go on to the last type of non-small cell, which is going to be your large cell lung cancer. There's not much to know about this. This is basically a diagnosis of exclusion. So it lacks any differentiating features on microscopy. So there's not going to be any evidence of keratinization like we saw in squamous cell. You're not going to see gland or mucin formation like we saw in adenocarcinoma. Nothing cytologically to indicate that it's small cell. Again, there's no differentiating features. This generally represents a diagnosis of exclusion. All I'd really say to know about it, it's peripherally located in most cases, and it accounts for about 10 to 15% of lung cancers. Probably not going to ask you a question on this because there's really not much to ask about it. It's basically just in the case, does it look like squamous, adeno, small cell? No, then it's a large cell cancer. There's really not too much to know here. So that's really all you need to know about the main things you need to know about your lung cancers. The only other thing I want to go over is a couple miscellaneous topics in your paraneoplastic syndrome. So this is going to be a group of disorders that can present in patients with lung cancer. So these are either going to be caused from an abnormal immune response that releases these hormones and cytokines because of the pulmonary neoplasm in the body, or from the mass itself that's compressing nearby vessels and nerves, which leads to these specific clinical manifestations. I'm going to keep these brief, but there's a few high-yield things you need to know about each. So first, let's start with Lambert-Eaton myasthenic syndrome. So this is a disorder of reduced acetylcholine released from the presynaptic nerve terminals, and it's from these antibodies that are against the presynaptic calcium channel, the voltage-gated calcium channels that prevent the release of acetylcholine. That's what happens here. You don't have as much acetylcholine, which is going to lead to a number of different things. Now, this is commonly seen in small cell lung cancer. It can be associated with a number of malignancies, but small cell lung cancer is the most common associated tumor you'll see with this one. That reduced acetylcholine is going to lead to proximal limb weakness without significant muscle atrophy. So this is the most common finding. So in the vignette, they're probably going to describe someone who has difficulty maybe getting out of a chair, walking upstairs, things where your proximal muscles are utilized. You're going to see that in the vignette. And then the key here to differentiate from myasthenia gravis is that muscle weakness is going to improve with activity with Lambert-Eaton myasthenic syndrome. This is different than myasthenia gravis because myasthenia gravis is worse with repeated muscle use, whereas Lambert-Eaton syndrome, actually repeated exercise or activity, forces the release of acetylcholine, which improves the symptoms. So muscle weakness improves with activity. The way that I used to remember that was Lambert-Eaton myasthenic syndrome stands for lunges ease my symptoms. So you do lunges, any kind of exercise, the muscle weakness is going to improve with repeated activity. Remember, that's different than myasthenia gravis. So lunges ease my symptoms, Lambert-Eaton myasthenic syndrome, LEMS, lunges ease my symptoms, make the muscle weakness better. Treatment, don't worry too much about this. You basically treat the underlying malignancy. There is a class of medications. They're the 3,4-DAPs. It's called amifampridine, and that's your main med that you'll use. And then it's kind of plus or minus the pyridostigmine because these acetylcholinesterase inhibitors don't really work that well. So you're basically going to stick with your 3,4-DAPs. This is the main medication that you're going to use for patients with Lambert-Eaton myasthenic syndrome. But don't worry so much about the treatment because you probably won't be tested on that. Now that's one of the syndromes you need to know. The other one is superior vena cava syndrome. So what this is the tumor is getting so large that the tumor is starting to obstruct the blood flow through the SVC. It's through the superior vena cava. So you have obstruction of blood flow through the SVC due to that invasion of that nearby tumor. It's commonly seen in small cell lung cancer, about 10% of the cases, which is mainly due to the rapid growth rate and location of the centrally located mass, which is right around the SVC. So that's the reason you'll see it more commonly in small cell. It's also seen in around 2% of non-small cell carcinomas. And so you can see it in both, but small cell lung cancer patient, it's going to be more common in about 10% of patients, like I said, compared to about 2% in non-small cell. Now, the key findings are going to be facial and neck swelling as well as dyspnea. So facial and neck swelling and dyspnea are going to be your most common symptoms that you'll see, the most common presentation. The facial and neck swelling, it can be pretty dramatic, and it's worse when they bend over. And then the dyspnea is from the edema that can narrow the lumen of the nasal passages in the larynx. It can potentially compromise the function of the larynx. It can cause dyspnea, stridor, cough, hoarseness, dysphagia, so a number of problems. And then finally, you may see distension of the neck and chest wall veins too. So this is what it looks like here. This is just an animation. So you can see the mass here is pushing on the SVC. So you have all this blood that's kind of stuck up here that can't get back to the heart. So the face is swollen. It's like, you know, you have all this edema. And then over here, you can see some of the venous distension. So some of the veins can be swollen here. So this is what the patient may look like with superior vena cava syndrome. As far as treatment, you're basically giving them the supportive care. If they're having any dyspnea, trouble breathing, you can give them steroids, diuretics, hydration, things like that. And then really you're treating the underlying cause. You're treating the mass to improve the symptoms in these patients. That's all there is to know about SVC syndrome. And let's move on to the final one, which will be superior pulmonary sulcus, also known as a PANCE tumor. So this is going to be a pulmonary neoplasm that's located at the apical pleuropulmonary groove. It's a superior sulcus. So it's basically a tumor that's located at the top of the lung, the apex. Because of that location on the top of the lung, as it grows, it's going to start to compress those nearby structures like the brachial plexus, the cervical and thoracic nerve roots, and it can lead to some of the unique symptoms that we see in this type of tumor. So you can see here we have this mass, and you see all of these different structures, all the brachial plexus, you have these veins and arteries, nerves. This mass is just pushing on all of these, so it can lead to a number of different symptoms. You can see this patient here has shoulder pain, which is one of your most common symptoms. So it's commonly seen in non-small cell lung carcinoma, about 95% of the cases. It's rare to see it in small cell, but very common in non-small cell lung carcinoma, so commonly in like adenocarcinoma and squamous cell. The symptoms that you need to know, the important manifestations you need to know, is going to be shoulder pain. This is by far the most common initial symptom of a PANCE tumor, and they present in anywhere from 44 to 96% of patients. And it's mainly caused just from the compression of that nearby tumor on the brachial plexus. That's what's going on. That's why you're having the shoulder pain. The second manifestation you need to know of is something known as Horner syndrome. So Horner syndrome, due to the compression of the cervical and the thoracic ganglia, those nerves there, these patients can develop ipsilateral, so same side of the compression, ptosis, anhidrosis, and meiosis. So ptosis is going to be that droopy eye, the droopy eyelid, anhidrosis, so no sweat, they're going to have dry skin, and then meiosis is going to be that constricted pupil. So droopy eye, dry skin, constricted pupil, all on the same side of those compressed nerves. The way that I used to remember that, this is really just a visual here for you, but hopefully you can remember this visual because it helped me. I remember a PANCE tumor, I think of pan, so right away I think of a pan. And then I think of, what do you spray in a pan before you start to cook with it? You spray with PAM, I mean maybe olive oil or something, but for the vignette, or for the mnemonic, remember PAM. So you're using a pan, you spray PAM in it. PAM stands for ptosis, anhidrosis, meiosis. And then this guy's like flipping the omelet, he's flipping the stir fry, whatever it is, and he's doing it for so long that his shoulder starts to hurt. So now he has shoulder pain. So hopefully when you see PANCE tumor, you can kind of remember this visual, and it'll give you your clinical manifestations, your shoulder pain, and then your PAM, your ptosis, anhidrosis, meiosis. Hopefully it did help me, that, that weird, funny visual. Finally, as far as treatment, it's really just reducing the size of the mass to improve the symptoms. So whether it's chemo, radiation, surgical resection, not a lot to know there. All right, let's finish up with lung cancer. Again, there wasn't a lot to know there, just those basic things that you need to know to be able to get the question right. So let's do 5 quick questions. First question, what treatment option is most effective in patients with small cell carcinoma? Most effective option in small cell is going to be chemotherapy. Remember, small cell lung cancer, that C stands for chemo. Question 2, mucin or gland formation visualized on histology is suspicious for which type of pulmonary neoplasm? That is going to be your adenocarcinoma. Question 3, the majority of malignant nodules are found in what region of the lung? Remember, 2/3 of malignant nodules are going to be found in those upper lobes of the lungs. Question 4, what type of cancer is most commonly seen in non-smokers? Most common type of cancer in non-smokers is going to be adenocarcinoma. And then finally, question 5, a patient presents with a cavitary lesion in a proximal bronchus that's visualized on imaging. Labs show an elevation in serum calcium levels. Which type of lung malignancy does this patient likely have? So remember, that's going to be your squamous cell carcinoma. Remember, cavitary lesion, C. Remember, squamous cell, all about your C's. Instead of the Q, it's going to be a C. So cavitary lesions, that's that central mass that we saw, that proximal bronchus, and then serum calcium hypercalcemia is your other C. So remember, squamous cell carcinoma. Okay, hopefully that was helpful. Please let me know in the comments if it was. And again, if you haven't subscribed to the page, please do. It really does help me out. And thank you so much for everything. And good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.